So our first speaker we're happy to welcome is Dr. Alan J. Brenzel. Dr. Brenzel is Associate Professor of Psychiatry and Pediatrics at the University of Kentucky and joined UK faculty in 1993 after completing a combined residency training program in psychiatry and pediatrics. Since 2010, via a contract with UK, he serves as the Medical Director for the Kentucky Department of Behavioral Health, Developmental, and Intellectual Disabilities within the Cabinet for Health and Family Services. He has developed broad healthcare policy expertise in many areas. His work has included modernizing the state Medicaid plan to include behavioral health and substance abuse services, increasing access to medication-assisted treatment, and much more. Most recently, he is serving as the co-principal investigator for Kentucky's Opioid STR and Opioid SOR grants that will bring over $90 million federal dollars to Kentucky to address the opioid use disorder crisis over the next 2 years. Please join me in welcoming Dr. Brenzel.
Okay, so I'm going to try to not wander too much since we're live streaming, and the monitor's down here, so I'm going to try to make sure I can advance slides. Thank you very much. So again, it's my absolute pleasure to be here, and I think I have a little less than an hour, and I'm going to try to stay on time. But I want to thank everybody for welcoming me here and allowing me to be part of this. As mentioned, I am a UK faculty member, so this is my home. But I spend a lot of time in another culture, and that's Frankfurt. And so I have the opportunity to share with you some of the efforts I'm involved with at the statewide level. But I have to say that this is an exciting moment for me because the vision of UK operating Eastern State Hospital was the vision that UK would bring its expertise and elevate the presence and role of behavioral health across UK healthcare and train the next generation of individuals that are going to care for some of the most vulnerable adults and children in our state. And to see the realization of that and to see the folks that are here from broad disciplines and the research that's being conducted, I couldn't be more excited about this. And I think this conference, I know it's in its second year, but I'm sure will only grow. And I was talking with Mark earlier, we're not going to get to population health without behavioral health. And until people realize that, we are stuck in some of the worst healthcare outcomes in the country in this Commonwealth. And I think you all are going to be part of fixing that as long as we can get the attention of policymakers, payers, and we know our mayor here already gets it. And so I think this is an exciting opportunity. So what I'm going to talk about is the Kentucky Opiate Response Effort, and that we refer to as CORE. And I am not the Kentucky Opiate Response Effort. I am part of a team of many individuals that is coordinating the state's response to the opiate crisis. And as you've heard, we have the great privilege of having a significant amount of federal attention to this matter and the privilege of having a significant amount of federal dollars. And we can credit our congressional delegation because some of these awards are based on formulas. And they've ensured that because of the scope of our problem, as the epicenter, that Kentucky has received a significant share of those dollars. So what we are charged with is being good stewards of those dollars. And these are dollars not for primary research. These are dollars for services. And these are dollars that are supposed to arrive in the community to address this issue. And we'll talk about it. So the purpose is somewhat evident of the Kentucky Opiate Response Effort, but our goal is by being guided by a recovery-oriented system of care. The CORE is to implement a comprehensive, targeted response to Kentucky's opiate crisis by expanding access to a full continuum of high-quality, evidence-based prevention, treatment, and recovery supports. And we are funding over 150 different projects and initiatives. And so I'm not going to have time to talk about all of them. But what I'm going to try to do is show you the framework that we are using to address the crisis, give you some examples of projects in each of the areas, and then give you a sense of all that's happening. So that word recovery-oriented system of care, that's kind of loaded. And the question people often have is, what does that mean? what it means is there's a big network of individuals that serve and interact with individuals with substance use disorder. And a recovery-oriented system of care is inclusive of all of those, all the way from acute care hospital to faith-based and community support organizations. That's what a network and a system of care includes. And our goal is to support long-term recovery of individuals and their families, because we know this issue impacts families to a great degree. And we want to create a culture that supports an individual's personal pathway to recovery. There's not one pathway. People enter the system at different places. They are different places along the continuum and the cascade of care that I'm going to illustrate. But we want a self-directed, person-centered, strength-based, and holistic approach, which for people in this room, those are all, I'm sure, core values of each of you. I do want to comment on language. Everywhere we go, one of our initial goals is to decrease stigma around substance use disorder. And so we all need to, as role models, educators, professionals, need to ensure that we're using person-first language. We don't refer to individuals as addicts. That is, in our minds, stigmatizing. There are individuals in recovery who choose to refer to themselves that way, and we respect that. But as professionals, we don't refer to people as schizophrenics. We don't refer to people as diabetics. We refer to them as individuals with opiate use disorder, individuals with diabetes. And I know that seems subtle, and sometimes we get careless in talking to each other, but it is a key message that we need to sort of remove our judgmental language, be sure that we're using morally neutral language, and medically accurate. The one that I still hear a lot is dirty drug screen. We don't want to use that language. That implies the person is dirty. We want to use positive drug tests. And the thing we're really wanting to do is even move away from a term that we promoted, which is called medication-assisted treatment, which is one of the key interventions for individuals particularly with an opiate use disorder. We're now wanting to refer to that as medications for opiate use disorder. Because we don't say medication-assisted treatment for diabetes, we don't say medication-assisted treatment for hypertension, and so why would we use a term that unique that sort of stigmatizes it? So we're moving away from using MAT to medication use for opiate disorder. And so as I mentioned, I'm here with many partners. This is one of those brilliant state bureaucracy slides, but I do want to just let you know where I sit. So these are the state partners. And sometimes in a crisis, there's a silver lining. And the silver lining for this crisis is I've been in state government for 25 years to a significant degree. And very often there are many silos and everyone working in their individual worlds, and we're not rowing together. But this issue has brought us together like no issue I've ever seen. Because of its implications, it's a behavioral health issue, it's a public health issue, it's a child welfare issue, it's a Department of Corrections issue, it's a licensure and public policy issue. And so I will have to say that I've never seen a time where there's as much collaboration within state government across these various agencies. And so you can see that box for Health and Family Services, that's where I sit. Within Health and Family Services, there's behavioral health. We have a substance abuse and treatment and prevention branch, which have toiled away in relative obscurity for many, many years, but are now being recognized as critical. But our public health colleagues, who have a lot of expertise in addressing community-wide health issues, have now recognized substance abuse and it's because our communities are telling them that. And the Department of Child Welfare, which is DCBS, critically important that they recognize that over 70% of the kids in foster care, which is now 10,000 in Kentucky, by the way, are related to one or more caregivers having a substance use disorder. And then I'm also with the Department of Medicaid Services, and in state government, that's the elephant in the room, right? That's a $9 billion healthcare program that now covers over 25% of all Kentuckians. So there's 4.4 million Kentuckians, 1.4 million of them are now covered by Medicaid. It's a good thing because access to treatment is critical to have a Medicaid benefit. The key for us is the sustainability of that number of individuals that are in the Medicaid program. But we have successfully added substance abuse to the Medicaid benefit, which, believe it or not, was not in the Medicaid benefit prior to 2014. We're the epicenter of an epidemic, and we don't cover substance abuse. So that was successfully added. We have a very robust benefit that includes all the way from peer support, case management, individual, group, intensive outpatient, partial hospitalization, residential, and hospital level care. So we, on paper, have a robust Medicaid treatment benefit, which has been key to addressing this epidemic. And then, just to mention briefly, the Justice and Public Safety Cabinet, Secretary Tilley, our Justice Secretary, I will have to say, is the most vocal supporter of treatment in state government as far as I'm concerned. Because what he recognizes is the impact on corrections has been overwhelming. In state correctional facilities, we now have over 25,000 individuals that are incarcerated. We have the highest rate in the United States of children who have one or more parent incarcerated. So 13% of our children have one or more parents incarcerated. We're going to have to build new prisons if we don't decrease the number of individuals who should more appropriately be entering treatment. If we can't divert those individuals, we're going to end up with private prisons and reopening mothballed facilities and incarcerating folks. And so they're strong advocates. And we work with education, the courts, and obviously the governor is very involved in this on a day-to-day basis. So I'm going to try out a new framework. This is the first time I've used this set of slides. We used to have the pillars: prevention, treatment, and recovery supports. And then we had infrastructure underneath the pillars. We decided that makes it a challenge to describe our sort of logic model. And so now we're into a beehive. So I'm not sure how this beehive is going to work. But basically what we're trying to illustrate is this is a complex issue. And in the center is infrastructure, which we have initiatives around infrastructure. And then harm reduction is a little bit off this side. That's a critical, separate, relatively unique. A lot of folks consider that as tertiary prevention, and so it's sort of part of prevention. And we've done a lot in Kentucky on harm reduction. And then as you go around the outside, we have treatment doesn't describe the whole continuum of treatment. And so we now have divided into early intervention, treatment access, and then ensuring evidence-based practices. And then where we're really moving now is to recovery support. People in early recovery have incredible challenges to maintaining their recovery, and so we're devoting significant attention to the issues of recovery support, which include housing, transportation, employment, socialization opportunities, and other supports for people that are in early recovery. So we have intervention in each of these, and in a short amount of time, I'm going to try to share with you some of those so that you'll see. Another way to look at this, we call it the Cascade of Care framework. And this really is a public health model, and I think was largely developed around HIV, early identification and treatment, recognizing that there were people who were not HIV positive and there was a need for prevention. There were those at risk that you needed to target. Once people were diagnosed as HIV, it wasn't a simple matter. They needed to be engaged first, then they needed to be in treatment. And then a critical variable is retention in treatment. And then the goal is obviously sustained recovery. So we also kind of use this continuum, and I'm going to break things down a little more nuanced than just the beehive into this Cascade of Care framework. All right, so in each of those areas, I'm going to show you some priorities and evidence, some of the projects that are targeting that area, and if we have them, sometimes yet we don't have the good outcome measures, but I'm going to show you some of the evidence that we're using to show our efforts in this area. So, infrastructure, the center of the beehive, the hexagon, and off of that, there's a number of things that flow from that, including decreasing stigma and discrimination, using and obtaining actionable data about the scope of the problem. But really recently, one of our ultimate priorities now is developing a statewide outcome measurement system. We can't keep funding things that don't work. We've got to understand, are we getting outcome? Are we getting bang for our buck? And target and enhance those projects, and then move dollars from, or assist those programs that are not delivering results. And if I had time, we could talk a lot about that process and what outcome measures and the legislation that was involved that's requiring us to develop a statewide outcome data system. And then quality and workforce, and then overall policy. So this is a map that we used when we sat down and first received this funding. It was the expectation that and our funding comes through SAMHSA, and so they ask us in our application to show us the data as to how we would prioritize our efforts. We are very lucky to have at UK, the Kentucky Injury Prevention Resource Center. If you haven't used their webpage, if you haven't used their data, you're missing out because it's publicly available on their website. They have their own CDC grants for surveillance. They've worked on reporting with the coroner and medical examiner. They're the public health, the word we always hear is bona fide agent of the Department of Public Health. But they provide incredibly actionable, local level, county by county data on overdoses, non-fatal overdoses, specific data on what drugs are showing up, and it's a very valuable. But we used a sort of heat map that included 4 factors: number of fatal overdoses, non-fatal ED visits, hospitalizations, and then the number of individuals that receive more than 100 morphine milliequivalents of prescription opiates. And this map shows you the darker red, and not a surprise here, the eastern part of the state, significantly larger problem. Doesn't mean it's not a statewide problem, but initial efforts were targeted in this direction. So we have these kinds of maps on an annual basis now that help us measure. So we have worked incredibly through CORE to expand infrastructure. One of the keys I've mentioned is access to medication for opiate use disorder. And we now have over 1,000 providers in Kentucky that have their DEA waiver. That includes both physicians and nurse practitioners. They are not all using their capacity to its full degree. I will have to say that 80% of medications are prescribed by 20% of individuals. Maybe that's okay, because some of those are our addiction experts and specialists, but we really want this to be managed in the community at a primary care level when appropriate. And so we need physicians who have their license to feel comfortable providing the medication intervention. And there are many barriers to that, and we could talk about that. Some of it's stigma. I don't want those people in my practice. I've got a little surprise for you. Those people are already in your practice, and they're coming there every day. And so you, as a healthcare provider, need to have the capacity to address that. And we have this goal that you manage hypertension in one room, obesity in the next room, and opiate use disorder in the regular flow of care, which destigmatizes the treatment, makes it available and ready locally. But those providers need to know they're linked to the other supports that are necessary to maintain and initiate recovery, because medications alone aren't the answer, as they're not for many healthcare conditions. So if you have a diabetic care team, you have access to nutritionists and podiatrists and ophthalmologists and others just like that. We want to ensure that the full care team is available. We believe in the role of peer support specialists. These are individuals with lived experience. They have an incredible ability to assist us, particularly with early engagement around the decision to seek care and to begin to enter into a journey of recovery. And so we've trained over 330 peer support specialists. We have many trainings now. The American Society of Addiction Medicine is very critical for us in terms of they have a multidimensional assessment that helps place people within the continuum. We at the state level now require managed care organizations to use ASAM in determining medical necessity. This means our providers need to be able to speak ASAM levels of care. They're also developing quality standards for providers so that we know what level do you provide. They have a system that are you medically supervised, are you medically intensive, are you hospital-based? You as a provider need to know what are you providing and where are you in the ASAM levels of care continuum. So we're bringing trainers to the state on a regular basis to assist providers. Because I go out and talk to providers and I say, what ASAM level are you? And they say, we don't know, we just know how to treat substance abuse. And we say, well, how do you know? And they say, because we've always done it this way and we think it really works. And then we say, well, how do you know it works? And then that's where we get lost in sort of the evidence. And the good providers want to know, is what I'm doing working? Where's the data? They can't be held responsible unless we can help them measure their outcomes. And we're training and consulting with rural providers. Casey's Law is a law that allows individuals to seek some external behavioral contingencies, which would be a court order to treatment. It's somewhat controversial. You know, the old motto, if you're not ready for help, go away, come back when you're ready. Long gone, right? Now we need to meet people where they are. We We need to use motivational interviewing. We need to understand how we can engage in harm reduction. But Casey's law for a subset of individuals, external behavioral contingencies are an evidence-based practice. So training on Casey's law. Everybody here knows what Casper is. I have to say, I've seen such an evolution in healthcare from the fact that all of the major healthcare organizations fought Casper, they lobbied against it, they said it was an unfair intrusion on the doctor-patient and clinician-patient relationship, administrative hassle, privacy violation. That was a bloody battle to get Casper mandatory. But Kentucky was one of the first states to make it mandatory, and I'll tell you, I wouldn't practice without it. It's a tool for all of us, and if you're not looking at it and using it, then you're missing an opportunity. Because I used to think, I'm an amazing clinician, I don't need that, I can tell. Well, guess what? When you start running Caspers, you realize maybe you're not the most amazing clinician, or there's opportunities to identify people who are transitioning from use to misuse. Because it's not intended to be a hammer, it's not intended to be a punitive, it's intended to help you identify people at risk who may need to have the issue addressed, and they may need to be linked to treatment. So we worked hard to keep our state prescription drug monitoring system at the forefront, use dollars from CORE. We have a full-time epidemiologist now that analyzes Casper data for us to identify trends. We're now linking criminal records to Casper so that you check that extra box, you can find out if the individual has a drug-related offense, which again may increase the level of suspicion or concern. And we're linking it as we go along to emergency room visits and the results of toxicology screens that may be available to share with you. Wouldn't you like to know if your patient was seen on Friday for a substance abuse overdose that maybe they didn't tell you about? That would be important information before you reach for the prescription pad. And again, not intended to be, we're also doing a lot of training around a specific curriculum. We have partnered with Betty Ford Hazelton at a huge level. They are in Kentucky quite a bit. We've leveraged their national expertise. And their journey is one that we find very compelling. It's an organization that believed in abstinence-only treatment. It is still the premier treatment provider of alcohol, substance use disorder treatment, and they espouse the abstinence-based model. Guess what happened? When the opiate epidemic occurred, they applied that model to opiate use disorder. Their outcomes were terrible. They had to soul search. They had to go through the process of understanding, why are our outcomes not good? Why are people not staying in treatment? Why aren't people getting into recovery? And what they realized was that for a significant number of individuals, the use of medications was a critical tool. So they developed an evidence-based model called Core 12, which integrates abstinence-only, medication-assisted withdrawal, and medication for opiate use disorder. And it's a patient-centered decision and a clinician decision. We believe we need all the tools in the toolbox. Certainly abstinence can work for some, but I would have to say that the data is not very compelling that for many or most that without medication, their journeys are going to be particularly challenging. And so we have worked with Betty Ford Hazelton. We now have a curriculum that's available within Kentucky to do trainings across the state that was developed in a consultation with Betty Ford. So I'm going to have to speed up here, but harm reduction, I mentioned, big deal. Keeping people alive is obviously one of the first steps to recovery, and that involves several things, both making sure we have naloxone or Narcan available. My motto is it should be taped to every guardrail. It should be as widely available as a defibrillator. It's as important to learn Narcan and resuscitation as it is CPR. The Surgeon General came here and said everybody needs to know how to resuscitate an individual who might be experiencing an overdose. So we have dramatically increased the number of naloxone or Narcan that's distributed. We're now up to 21,000. We know this through the pharmacy distributor system. It's really hard to track right now who's giving it out, where it's available, who has it. We'd love to know how often is it used and what are the results, but it's not often that we're able to get that. As you can imagine, people who use it may not be in a position of reporting to that. But we're already for 2019 going to far exceed. We don't know what the right number is. Some of us have suggested 60,000 might be the right number. West Virginia set a goal of 50,000. but we have to continue to ensure that Narcan is widely available. This thing up in Cincinnati, I don't know if you've read the paper about that, very troubling. So they've had recently 49 deaths in a couple of weekends from a new population that's not had, we haven't targeted for Narcan, cocaine users who may have a different pattern of use where they use recreationally on weekends. So it's not the folks that we may have been targeting, but the cocaine is now laced with fentanyl, and folks don't even know they have it, they don't even know that it's on board, and they've had a rash of deaths. So again, we have to widen the circle in which we're making Narcan available. We have a SAMHSA overdose prevention toolkit that we've been pushing out through our regional prevention centers. Every community mental health center has a regional prevention center. Each of those have the ability to locally determine their priorities, but we're asking them to provide and push out this overdose prevention toolkit. It's the number of providers we've trained. One thing I'm incredibly proud of, I'll just tell you, as a Kentuckian, we in Kentucky passed a harm reduction syringe exchange program, the only southern state to have such. And it wasn't done at the Frankfurt level other than we got out of the way. And our local communities now have the ability, should they choose, to operate a syringe exchange program. And over 50 of our communities have chosen to do this. They've educated their city and councils and local government, their public health boards, and for no other reason, if not to prevent the spread of disease in their communities, they've authorized these. And they vary in terms of operation and hours and what happens there. But the ultimate goal is not to hand out syringes, right? The ultimate goal is to provide a front door to individuals who are seeking to begin their journey to recovery. Because if you choose to make a decision to protect your health by going, you have already taken the first step. And so making sure that these syringe exchange programs have peer support specialists present, treatment counselors readily available, other kinds of healthcare supports, testing for Hep C, testing for HIV, and making sure that they're readily available. And if you want to see creativity, go out and visit some of these. It's amazing to me. And what it shows me is communities are not waiting around for the federal government to fix this, or they're not waiting around for the state government to fix this. Communities are mobilizing to fix this. And they have a variety of, again, mechanisms to do that. But we have So now I'm going to talk briefly about prevention, because sometimes that gets short. When we're in a crisis, people are flowing down the river and we're throwing life jackets at them. Sometimes we forget to go up the river and figure out why are they falling in the river, right? Because we're too busy pulling people out of the river. And so we do need to focus on prevention. We're expected to spend a certain percentage of this federal money on prevention. And so we'll talk some about that along this continuum. So we want to focus on people who are opiate naive, who've never been exposed to opiates. And then we want to take a look at people who have been prescribed opiates and understand of those which are at risk to progress from use to misuse. That's an interesting population to look at. So we'll talk about those two and some of the activities. And so there's primary prevention, and then there's other efforts. And so I'll talk a little bit about each of these. One of the reasons we know it's important to get to kids and to look at age of onset of other substances is because each of those substances increase the ultimate risk of illicit prescription opiate use, right? So this is if you're 12 and younger, and that's the blue bar, and you are already using cigarettes, guess what? You have about 11.1% chance of later developing prescription opiate use. If you're 13 and you smoke cigarettes, it's 6.6. And then, if you've never used it, it's only 1.3. So we have a target group right there. Kids who are using tobacco at a young age. Alcohol, same kinds of results, even more significant, 19% risk. If 12 and under, you're already using alcohol, I mean, it is middle school, right? And then cannabis as well. And so looking at these individuals who might by 10th grade already be using illicit opiates. And so I know there's some important work in this room going on around tobacco, initiation of tobacco use and other substances. So we have engaged in prevention at two levels. One is creating a community and providing community coalitions that, as I said, are rising up from grassroots, and they're developing and supporting the efforts of those local coalitions to ensure that they have the support they need, the training that they need, the materials that they need. And we have collaboration specialists now that we're funding in each of our regional prevention centers. But then targeting specifically the youth within the community, we believe in some overall projects that enhance social and emotional well-being, provide protective factors for the use and progression of substance use disorder. And we have funded some youth empowerment specialists at each of our centers. And some curriculum out there that you may have heard about. We support Sources of Strength, Too Good for Drugs, Positive Actions. These are all somewhat manualized, readily available. Some of them are proprietary and require a fee, but we've been helping support the use of these, which are all about health and wellness promotion, resilience building. They are effective for things like bullying and other risk factors. And so hopefully you're seeing some of those in your, and a lot of this is happening at the local school level or the local school board level, bringing these to the communities. Opiate stewardship could be another hour-long lecture. This is the idea of us as health professionals looking at our utilization of opiates and how are we managing and prescribing. Because we use 99% of the world's production of hydrocodone in the United States of America. I didn't believe it, but it is true, 99%. There's bucket loads of this stuff that was prescribed. We all got duped about the potential addictive nature. We all got subjected to wanting to manage our patients, being told that pain was the fifth vital sign, that we were bad providers if we didn't treat it early. I was trained early, fast, and hard. If you get pain, you've lost the battle. You're a bet. We were measured in our satisfaction surveys about whether we had a smiley face or a frowny face on our patient satisfaction tools. That helped perpetuate and create this epidemic. And so we now are encouraging healthcare organizations to internally look at their prescribing. And UK Healthcare has been a leader in this. We've got several folks that helped at UK look internally. Dr. Chang in surgery developed at his trauma patients in conjunction with the College of Pharmacy. Started looking at it, and they have one graph that says that if they prescribed opiates, somebody left it from the hospital with opiates, 20% of them would still be on it in a year. So that means they have a potentially life-threatening dependency on a medication. And if you knew that you were going to prescribe something that 20% of individuals will develop a life-threatening complication, that requires a hard look. And so this is all about reevaluating, making sure we're using non-opiate interventions first. We need to manage pain. We need to reassure our patients that we will manage their pain. But it's about setting expectations, using things that used to be considered not worth it, Tylenol, ibuprofen, other kinds of medicines to monitor and treat long-term pain that are non-opiate, and then using opiates, but then taking the opiates off first, not last, because we have sort of inverted the pyramid in terms of. And so we are going to leverage UK's experience. We funded the Kentucky Hospital Association to create a statewide opiate stewardship initiative. I think over 70 hospitals have now signed up. We in government, we could mandate the prescription of opiates, but we don't want to do that. We want the clinical community and providers to develop what are the standards. And SAMHSA and CDC have guidelines, but what's neat is the hospitals are going to get together and come up with a set of standards for what's a quality opiate stewardship program, and then hospitals are going to submit what it is that they do, and they're going to be sort of rated. It's going to be like soccer. Everyone's going to get a trophy probably. You're going to be good, gooder, better, best, excellent. Everyone's going to be good. But we want to be able to self-monitor and encourage hospitals to look at system-wide, identify their outliers. Is there a reason this prescriber is an outlier? Maybe it's appropriate, but maybe it's not. And the Joint Commission is now expecting opiate stewardship to be part of its certification process. The problem is they haven't set any standards, and they just have this little phrase that says you have an opiate stewardship committee and it does something. But we want to define what that something looks like. This is just the overall prescriptions of opiates over time. It's trending down. It's a good news, but it's not trending down as fast as we'd like. That's still a boatload of opiates that are being prescribed. Some other things have happened. The 3-day limit maybe we don't like that, but I can tell you where I sit, the data is egregious about the number of 30-day opiate prescriptions for sprained ankles, stitches, wisdom teeth extractions. It's still out, it was still out there. And so as an emergency measure, and there's exceptions to that, all you have to do is document the rationale for why you provided more than 3 days. Nobody's gonna come knock down your door and haul away your computers and take you out in handcuffs for managing people's pain, but it creates a pause. If you need more than 3 days, you need to think about why and what the plan is gonna be. So on to treatment, and so in this box there's 4 different hexagons that we're going to talk briefly about. Those that are diagnosed, we need to identify them and get them into treatment. Those that are engaged in care already, we need to make sure they have access to the kind of services that we talked about. We need to get the treatment initiated, and then we need to retain them in care. And so we'll talk some about each of these areas in these. So screening, if you're in a primary care setting and you're not screening, then I would have some concern that you're not adequately managing the healthcare needs of your patients. So, and then if we get people screened, how do we get them engaged? So a couple of things that we're really encouraging are SBIRT. Everybody knows what SBIRT is, I'm sure by now. We work with the Kentucky Healthcare Consortium, developed a provider toolkit that helps providers learn how to get certified to use it, how to get paid. It's covered under the Medicaid program. We got that in the Medicaid benefit. You can bill a code for SBIRT in a primary care setting. And we've trained, 188 physician offices to be able to implement SBIRT. And so that's a critical tool. Another tool we're really have been impressed with the results are our communities that develop what are called quick response teams. These are teams, and they're variable across the state. Northern Kentucky probably pioneered some of this, in that they take a mental health professional with substance abuse credentials and skills. They take often a law enforcement person and a peer support specialist. And they monitor those that interface with the system around SUD or opiate use disorder. So it may be they monitor EMS contacts for overdose. It may be that they monitor the police blotters for anybody where there was a call where it was identified, or emergency room visits for non-fatal overdoses, or people who never made it. And they send somebody to that home to try to understand, is there something we can do to intervene and help? And I was skeptical. I thought, well, all right, a police officer. Who is going to open the door if a police officer knocks on the door? Everybody's going to duck under the table, right? What very often they're finding is it's families who are desperate for help. And those families are grateful, and they are able to work with the professionals to understand what tools are available to assist them. So we are funding a number of quick response teams across the state. I think Fayette County has a quick response team, that's one of the models, and we're interested in determining of the models which are more effective, what are some of the issues, how do you get the notifications, what are the confidentiality issues. I mean, there's all kinds of challenges, but it's a very effective tool, and it sends a message that we care. And I think one of the things that's in suicide, what we found is contact post-emergency room visit for suicide is a critical intervention that can be very preventative. So, increasing access to treatment. We have spent a lot of time in this area. I won't be able to go into a lot of details, but ensuring access to quality care. We have some target populations that I want to share with you that we initially believed were really critical. And then we've put money where our mouth is here. One of the things that we started out is SAMHSA expects us to decrease our overdose death rate. And you all have read about the UK Healing Communities grant, right? Incredible opportunity, $86 million over 5 years, partnering with the state and UK. It has a stated goal of decreasing overdose death rates by 40%. So we're like, great, if we can pull that off, we'll be a national model for sure. But we have had that initial goal of decreasing overdose deaths. I think most of you know we have 1,500 deaths a year. We did level it off. We've had over 10% increases every year. The 18 numbers I can't talk about yet. I've seen the Office of Drug Control Policy officially releases them. We had a big spike in early 18 and end of 17 when fentanyl hit. we went up in 17, 10.3%. We think we leveled it off in 18. We were hoping for a reduction. Final numbers are still being toyed with, but I think we've stopped the curve, which is a big accomplishment, as opposed to actually a significant drop. I don't think we're going to see that. But who's most likely to die of an overdose? Somebody who's already overdosed. And so one of our early goals with this funding was to increase the likelihood individuals who hit an emergency room for an overdose have the opportunity to begin their journey to recovery in an emergency room. Because historically, this is a challenge. People who get Narcan are agitated, they're not happy, their brains are screaming for a fix, the hospital gets agitated, put a security guard down there, they feel like their staff are at risk, people don't know what to do, and so what happens a lot is people find a way to disappear. Or, we want you out of here, please get out of here, here's a piece of paper if you want some help, call this number when you get around to it. That doesn't work. We looked at our overdoses, 20 to 30% of people who overdosed were getting into treatment within 6 months. That's not good. If that were the same, for other illnesses, we'd be all looking at ourselves as massive failures, right? So we diagnose somebody with a heart attack in the emergency room, and then we send them out and say, hope you can find some help for that. So it's been an evolution. We want emergency departments to feel competent to manage withdrawal for what it is, a medical emergency, in my opinion. We want them to be able to look that person in the eye and say, you don't have to live this way. I can manage your withdrawal. I can treat you with medications today, right now, this minute, not down the hall, not across the street, not 2 days from now, not get on a waiting list, right now. And so we now, and I'll have to credit Dr. Humphreys at UK, it's been an evolution, it's been a culture change. I couldn't get them to get out Narcan 5 years ago. They're like, oh no, we'll be liable if somebody uses it wrong. But we've come a long way, and now I think and Dr. Humphreys is a great spokesperson, because what he says is, when I have a trauma patient, I have a team. I have orthopedics, neurosurgery, vascular surgery, I have everybody, and I can bring a team. If somebody comes in near death and resuscitated for substance abuse, what do I got? I got nothing. So that's changed. So we're funding what we call bridge clinics. And that's the idea that we connect services at the time someone overdoses. We believe peer support is a critical intervention. Somebody who can look that person in the eye and says, look, I was living like you 3 years ago. I was living under a viaduct. I lost my wife, my job, my house, my health. But now I'm working for a living. I'm paying taxes. I know this can be done. Let me show you, and let's get you on the road to recovery. I can talk to you about getting somebody to assess you. We can treat your withdrawal. We can begin your journey to recovery right now. And that's where we want to get. And we've invested in bridge clinics at UK. UK, I think, is treating in the ER and moving people over to this Center for Drug and Alcohol Resources first bridge clinic, I think they call it, over on Angliana. We funded this at University of Louisville, St. Elizabeth Healthcare, which has 5 hospitals. Baptist Health is now contracted to provide ARH and Norton. They're all in on this, but it is a slog to change the culture in the emergency department, but we're working on it. We've seen 1,200 patients in these variety, and they all have a little bit different models. Whether the peer support work for you, which is a challenge to hire them. HR often says, oh, well, no, I can't hire anybody with a criminal background, so, oh, well, there we go, we can't hire peer support with. But we're getting hospitals to recognize the unique role. Some of our bridge clinics have a community organization that brings the peer support specialist in. Some of them have licensed clinical staff that provide it. There are many models. Happy to talk to anybody about all of those. It to me is a critical issue, and it's evidence-based, and it's up at Yale, and they showed as high as 60% of people who have an overdose can get engaged in treatment and stay in treatment for 6 months. So one of our critical goals is increasing access to office-based opiate treatment. We want this to be done well in primary care. One of the things we have done is we funded the Kentucky Primary Care Association with a significant amount of resources to serve as a consultant to all of the FQHCs. FQHCs are a critical provider, particularly in Eastern Kentucky. And historically, not all of them have offered behavioral health services, and very few have offered substance abuse services. They now realize that they need to be doing that, and so this allows them to get consultation. Because you got to figure out, how do I set up my office? what does my documentation need to look like? What's my EMR template? How often do I need to see people? What kind of drug testing do I need to do? What happens if? How do I know they're going to their outpatient appointments? There's a lot of variables to being willing to raise your hand and say, I want to help, but I'm a primary care doc and you need to help me figure out how to help. And so we've given more than $1 million to the Kentucky Primary Care Association. They're having a meeting here in town to talk about that. We've also created another target population for us that's high risk is those re-entering the community from correctional settings. High risk. People lose their tolerance. They come out of jail, they go back to their previous pattern of use, and they overdose. So we have targeted those. One of the exciting things that's happening is the first county detention center has agreed to do medication treatment for opioid use disorder inductions in their county detention center. So Kenton County has a addiction specialist, a treatment program. They prescribe, they're doing both buprenorphine, but also Vivitrol. It's really kind of sad in a way because in northern Kentucky, the quickest way to get treatment is to get arrested. And I hate to say that that's the quickest way to get treatment, and we shouldn't have a system that the quickest way is to get arrested. So I'm going to have to speed up. I don't want to delay the schedule today, but we're also supporting access to injectable naltrexone, which is Vivitrol. UK College of Pharmacy has been very involved. We believe local pharmacies should be able to do this in conjunction with a treatment team. They give flu shots, they give other vaccines, they give sometimes depot antipsychotics now, and we're working with them to increase, because if we give Vivitrol in corrections, who's going to see them when they get out? Because a lot of offices don't have needles, they're not used to administering injections. We need to make that available. So we have another goal of ours is treatment on demand. The ability to pay shouldn't be a barrier to treatment. We've put $4 or $5 million into what we call treatment stipends. Treatment stipends means if a person, for whatever reason, doesn't qualify for Medicaid or has a high copay on a policy they purchased but can't afford the $10,000 copay, we will reimburse the residential provider for those services. The money doesn't go to the individual, it goes to the provider. So it's up to the provider to access these dollars. But we're putting a significant amount of money into the hands of providers so that they should not turn away an individual based on their inability to pay. And if you hear of a provider that doesn't seem to know about this, Operation Unite out of Eastern Kentucky is managing this benefit for us. The criteria are they have to have some opiate use disorder, because that's where this money's coming from. And then they have to be a Kentucky resident, and we want to be the payer of last resort. Hopefully you all know by now the Kentucky Treatment Locator is online. That's a big deal. There's a phone number on here as well if a person would rather talk to a live individual. This is designed to keep an up-to-date list on a day-to-day basis of who has capacity. Still not where I'd like it to be, because I'd like everybody to, and providers are updating it, and they're pretty much all saying they have availability. The original idea was who has a bed today, but the thing is we're expanding capacity so much that there shouldn't be waiting lists. Individuals should be able to get into care right away. And so treatment retention, I've mentioned that one of the keys is that medications are critical, and we've done a lot to, another population that I won't have time to talk about is pregnant and parenting women. A lot of good stuff happening here in the UK around that. The key in that is just integrated model where women are able to get their OB care, their substance abuse care, their medication prescribing in a coordinated fashion, and that they have supports around other psychosocial supports, getting child welfare involved. We've expanded dramatically the number of programs that will admit women with their current children. And that's critical, because if I have a 2-year-old and I can't leave and go to residential for 30 days because DCBS is going to take away my other child, educating DCBS about what does recovery look like, big slog for us. Judges still think if you're on buprenorphine, you're a drug addict and you need to have your kids taken away. Man, that's been tough to get around. But people can be in recovery and parent when they're in treatment, and that's one of the things. And then we've worked on community reentry coordinators, which are people that assist people who are coming out of corrections. And the last thing I'll talk about with very little time is those recovery supports. We've done a couple of things. We understand there's the transitional housing, which is kind of a bad word in the housing world, but for us, there's usually about 30 days of residential treatment, and there's this period where we need some kind of supported housing as people transition to full independence. And there's now a national accreditation organization, because communities are concerned, who's in this house down the street, and how do I know these people are in recovery? We're working with NARF, which is the National Alliance for Recovery Residents, to create a certification process. Because what we find is some of our communities are passing ordinances, no recovery, no halfway houses in our city or none in our neighborhood. This is a way of developing some quality standards so people will know. We're putting money into a couple of things you should, in these pilot counties, we're calling them access to recovery programs, where you come physically, you get your recovery capital assessed, and if you need vocational support, if you need clothing for a job interview, if you need transportation, you need assistance with housing, for 6 months, we have funds that we can devote to this kind of recovery supports, and we hope to expand that beyond these pilot. FAHI, I don't know if anybody knows FAHI, that's the organization that we're funding to develop these. We're also funding recovery community centers. These are the locations for those. These are places where in the community, sort of like a drop-in, where people in recovery can access peer support, mutual aid groups, advocacy, housing, employment. A little different than the ATR, which is basically a stipend program with the financial resources. These are actually recovery communities, and they might host things like Double Trouble in Recovery. We funded that, Smart Recovery and Friends. And then the last thing that I won't get to talk about is employment. I think the mayor alluded that our employers are desperate for healthy employees. It is an economic drain on Kentucky when we can't find enough qualified individuals. We're not going to solve a lot of Kentucky's economic issues. But our employers are ready to step up. They want to be part of the solution, and so we want to help them. We're funding career centers. What we need to do is prepare people on this side where the people are to enter the workforce, but we need our employers to be ready to create, and we've struggled with what to call this. I think we've decided on site. We were calling it recovery-friendly workplaces. Some people want to call it second chances. I mean, why second chances, right? Because we don't do that with anything else. So we don't want to call it second chance employment anymore, but we want employers to be able to be part of the solution, and we created a statewide toolkit that folks can access for. If I'm an employer and I want to know how to address opiates in the workplace, we've worked with the Kentucky Health Collaborative, which is Ford and UPS and another big, and GE, and they are now wanting to be part of the solution. So I'm going to stop there. I apologize for going over. Hopefully I didn't interfere with the morning break. And I'm going to be around at the first break and happy to talk more. But hopefully that gives you an idea of some of the many things that are happening. And hopefully you've seen some of those things in action.